Bismillahirrahmanirrahim. This video will describe the pathology of rheumatoid arthritis. These are the references for this video. The classic case scenario for rheumatoid arthritis is a 44-year-old female this female present to your office complaining of chronically swollen finger joints over the past 6 months. She tells you that the swelling and pain are usually most severe in the morning, but they resolve within a couple of hours. The rheumatoid arthritis can be defined as a chronic multi-system inflammatory disorder that produces a non-suppurative, proliferative, and inflammatory synovitis that often progresses to destruction of the articular cartilage and ankylosis of the joint. Or simply, we can define this as a chronic autoimmune disorder that principally attacks the joint, producing a non-suppurative, proliferative, and inflammatory synovitis. As it is a multi-system disease, both the joint and the extra-articular sites are affected. The characteristic joint lesion of the rheumatoid arthritis are destruction of the articular cartilage and ankylosis of the joint. The extra-articular lesions are present in the skin, blood vessel, heart, muscle, and lung. It should be differentiated from other autoimmune disease such as systemic lupus erythematosus and scleroderma. About 3 cases per 10,000 populations are reported worldwide, hence their prevalence is about 1% of the world population. Peak age for this disease is about 20 to 50 years, and there is more female predominance. Females are thrice commonly affected than that of male. As far as the pathogenesis of rheumatoid arthritis is concerned, this autoimmunity is started by CD4 helper T cells, and as in other autoimmune disease, the pathogenetic mechanism or pathogenetic predisposing factor can be genetic and environmental, which are responsible for the course of the disease, including its development to persistence. HLA-DR4 is linked with rheumatoid arthritis because HLA-DR4 vinculin epitope on citrullinated protein mimic an epitope on various microbes and can be presented by class 2 HLA-DR4. Hence, this allele, HLA-DR4 allele, is related with anti-citrullinated protein antibody positive rheumatoid arthritis. 50% of risk to develop rheumatoid arthritis is linked with genetic susceptibility. Then the environmental factors are responsible for the formation of citrulline protein such as smoking and infection. They set off antibody production. Antigen-antibody reaction is responsible for the initiation of inflammation and cytokine release, which can subsequently recruit more cells and induce tissue damage. The helper T1 cell, T helper 1 cell, they are lineage of CD4 effector cell. They secrete gamma interferon and they act on macrophage and resident synovial cells, and due to their effect there is secretion of TNF and interleukin-1 from the macrophages, and these in turn act on resident synovial cell. There is release of proteases from the synovial cells, and these in turn going to damage the hyaline cartilage. So there is destruction of the higher end cartilage, and this TNF is an important target for the therapeutic effect or pharmacological effect. The T17 T helper 17 assist B cell to make antibody, activate the macrophages and recruit other immune cells to the inflamed area. And these helper helper 17s, the subset of CD4 helper 17, they secrete interleukin 17, which recruit more neutrophil and monocyte to the area of injury or area of inflammation. Activated T cells, they are also involved in this pathogenesis. They express rank ligand on their surface, and hence they start osteoclastic activation and bone is reabsorbed. So through these cytokines, the morphological changes or tissue damage occurs. This illustration from the Robbins is describing the events that we just discussed. It is showing when a susceptible host is exposed to an arthritogenic antigen, that is failure of the tolerance and initiation of the events. Also, beside this failure of the tolerance, there are responsible environmental factors which lead to enzymic modification or circulation of the citrullination of the protein, and these will result in a T and B cell response to the self antigen and helper T17, T helper 1 and antibodies. They work together and they work together and they will lead to aggregation or recruitment of inflammatory cells, and these inflammatory cells and their released cytokines are responsible for the activation of fibroblast, chondrocyte and synovial cell, and finally there is pannus formation and destruction of the bone and cartilage due to proliferation and also due to cytokine effect. Things are not very simple that we have just summarized. You can see that this illustration from the Nature Review, there are many mechanisms simultaneously and there are other mechanisms also. So there is plethora of cytokines which are involved in all these activity. The synovium in the rheumatoid arthritis contain numerous active germinal follicles, and these germinal follicles are responsible for secretion of various immunoglobulin by the plasma cells. So these antibodies are basically against self-antigen, and many of these antibodies are specific for citrullinated peptides. Hence, these are also termed as anti-citrullinated peptide antibodies. Anti-citrullinated peptide antibodies. These citrullinated peptides are basically the peptides in which arginine residues are post-translationally converted to citrulline, and many of the proteins are affected or modified by this mechanism, such as fibrinogen, type 2 collagen, alpha enolase, and vimentin. Anti-citrullinated peptide antibodies are diagnostic markers for rheumatoid arthritis, and they are present in about 70% of the cases. Then there is another antibody, that is RF factor. This is basically autoantibodies to IgA or IgM that binds to IgG Fc region, and these antigen antibody complexes can be deposited or these can be deposited in the joint, and there are many false positive or false negative results for the They are recorded for the RF factor. So in this picture, in this illustration, all the events that we have summarized are seen. There is genetically susceptible host, and in this there is activation and central, there is activation of CD4 T cells, and these CD4 helper cells act through liberation of various cytokines such as TNF, interferon gamma, and interleukin 1, which activate B cell. There is activation of B cell, epithelial cell, and macrophages. There is formation of anti-IgG antibodies, which we have termed as rheumatoid factor, and these endothelial cells, when activated, will release adhesion molecules, and macrophage activated and they release cytokines and proteases. All these together, they are going to form immune complexes in that area, and also there is recruitment of inflammatory cells, or there is also pannus formation or apron shaped area formation within this environment, and all these factors, they are going to damage the synovium, small vessels, and collagen of this area, and as a result there is destruction of the joint structure. If it is long standing, there is fibrosis of the area. Subsequently, it is fused or ankylosed, and these destruction will result in deformities of the joint. After any arthritogenic stimulus, there is a stimulation of the synovium, and these synovial cells then proliferate. There is increased in vascularity and uh, synovial hyperplasia that result in fibrin exudation, and these fibrin exudation in the joint cavity, if it is in excess, it forms small nodules, and these nodules float freely within the joint cavity and termed as rice bodies. The normal synovial lining is about 1 to 4 cell thick, but in rheumatoid arthritis it can become 8 to 10 cell thick, and as a lesion progresses, it is thrown into numerous folds. There is simultaneous influx by the lymphocyte and plasma cell and mast cell, and the hyperplastic inflammatory synovium, soon it starts slowly invading the articular cartilage, and the area adjacent to it cover and isolate it from the joint space. This covering is termed as pannus. The aggregate of the lymphocyte, they also transform into follicles. So there is juxta-articular bone loss. As we have seen in previous discussion on pathogenesis of this disease, the demolition effect of the pannus is not limited to the bone. With progression, it involves tendon and ligament, which lead to joint deformity. If the joint is destroyed, there is fibrous ankylosis first, then it is going to ossify and form bony ankylosis. So the features can be lymphoid follicle formation, erosion of the cartilage, and underlying dead chondrocytes, subchondral pannus, and bone erosion, activation of the osteoclast, and here you can see that fatty marrow is also present. Bone is also eroded. So as the pathogenetic mechanism alter the morphology, the synovium become thick and edematous, and it is hyperplastic, and it is bulbous fronds are formed in this edematous, thick and hyperplastic synovium. On the extreme, you can see in this picture there is This is rheumatic arthritis synovium with numerous capillary projection, and there are pale focal areas of fibrin deposition there, and brown color is due to hem, hem, hemosiderin deposition, and these are derived from the accumulation of old hemorrhage. So the histopathological features of the rheumatoid arthritis are uh, synovial hyperplasia and proliferation, inflammatory infiltrate presence, angiogenesis, presence of fibrinopurulent exudate, and osteoclastic activity. The pannus is the mass, which is basically an edematous synovium with inflammatory cells, granulation tissue, and fibroblast, and this creep over the articular cartilage and responsible for the major demolition act in the rheumatoid arthritis. Then bone ankylosis. After the destruction and demolition, there is union by fibrous tissue first, and then ossification of the fibrous tissue. This illustration is showing the histopathological changes that are seen in rheumatoid arthritis. There are deposition of the lymphocytes and plasma cells, which are forming active lymphoid follicle within these bulbous fronts, and there are also villus hypertrophy and angiogenesis. Another name for these lymphoid follicle is Ellison-Gomle bodies, and the rheumatoid arthritis is it also contains giant cells. So presence of giant cell is another histologic characteristic of this rheumatoid arthritis. The rheumatoid arthritis of microscopy show marked chronic inflammation with aggregates of lymphocytes and plasma cells that are lying just beneath the synovium. There is proliferation of these synovium, and this uh, creeps on to the bone surface and cartilage, and this proliferative structure is termed as pannus. Another feature of rheumatoid arthritis is presence of rheumatoid nodule, which is present in 25% of the cases, and it is frequently present on the pressure areas such as ulnar aspect of the forearm, elbows, occiput, and lumbosacral area, though it is recorded in the viscera also, such as lung, spleen, pericardium, myocardium, heart valves, aorta, dura, and other viscera. Uh, Microscopically, they are small, firm masses, and these are round to oval on morphology, and they are actually, or under the slide, they are necrotizing granulomas with central zone of fibrinoid necrosis. There is fibrinoid necrosis that is surrounded by a prominent rim of activated macrophages with lymphoplasmacytic infiltrate. So the characteristic morphology of rheumatoid nodule is shown here, which is showing small firm nodules. This is a high power view of rheumatoid nodule, which is showing central fibrinoid necrosis, firm round to oval nodule that is showing central fibrinoid necrosis in the upper picture, while here there is high power view that is showing epithelioid histiocytes, lymphoplasmacytic infiltrate within this area. This is the microscopic appearance of a rheumatoid nodule that has got a central area of fibrinoid necrosis, and this central area of fibrinoid necrosis is surrounded by palisading epithelial macrophages, and there is presence of other mononuclear cell. These are non-tender nodules that are present in about 1/4 of the patients of rheumatoid arthritis. Another rheumatoid nodule with the characteristic histology. So what is here? This is fibrinoid necrosis that is surrounded by epithelioid cells and lymphoplasmacytic infiltrate. The severe form of rheumatoid arthritis is associated with leukocytoclastic vasculitis, in which there are acute necrotizing vasculitis of small and large arteries, and in the site of this is pleura, pericardium, and lesion is of chronic fibrosing type. The purpura, cutaneous ulcer, and nail bed infarction are also common. Ocular changes are uveitis and keratoconjunctivitis, like that seen in Sjogren syndrome, are also noted in rheumatoid arthritis. Now, clinical features of the rheumatoid arthritis: the disease is progressive and it adds on joints over time. Small joints of hand and feet are affected first, followed by wrist, ankle, and elbow, and finally the knee joint. Hip joint are affected lately. The joints are swollen, warm, and painful. So the clinical feature, the morning stiffness lasts more than 1 hour, and it also has no relation with the activity, as osteoarthritis pain is related with the activity, but here there is no relation with the activity. The patient are often tired and don't sit properly, that there is joint enlargement and disability as the disease progresses, and after the disease progression there are various form of deformities such as radial deviation of the wrist, altered deviation of the finger, and flexion and hyperextension of the fingers, that are termed as swan neck and boutonniere deformity. And then there are many constitutional symptoms, as the immune system involves whole of the body, and the symptoms are fatigue, tender tiredness, then weight loss, anemia, muscle pain, lack of energy, loss of appetite, inability to sleep, low grade fever, and lung, heart, and eye problems. It is separated from other arthropathies by anti-citrullinated antibodies positivity and characteristic radiological features. As we have seen in the pathogenesis, that the disease is associated with demolition of the tendon, ligaments, and joint capsule structure, so it will result in various deformities of the joint. Some are characteristic of the disease, such as radial deviation of the wrist, ulnar deviation of the finger, and swan neck deformity, which is basically flexion and hyperextension abnormality of the finger, or uh, there can be deformity of the thumb. So if the joint is deformed, it is not stable, so there is no or minimal range of the motion, and sometimes due to weakness or weakness in the muscle, Baker cyst may develop in the posterior knee. This is classical ulnar deviation of the finger with swelling in the metacarpophalangeal joints. Cross appearance of the hand in rheumatoid arthritis. One abnormality is this ulnar deviation of the hand that is prominent, and also there is flexion, hyperextension deformity, that is also termed as swan neck deformity. The fingers are also sausage shaped. As it is a multi-system disorder, it is frequently associated and it exhibits extra-articular features such as sicca features, dryness of the eye, dryness of the mouth, and dryness of the mouth and eye. And also there is Raynaud's phenomena, carpal tunnel syndrome, rheumatoid nodule, which we have seen many pictures we have seen in earlier slides. They are present in many sites, and pleural effusion is also present with rheumatoid vasculitis. The 1/4 of the patient affected by rheumatoid arthritis, they recover completely, while the other quarter they have got the slight functional impairment, while about half of the cases they develop serious, progressive and disabling joint disease. Mortality in this disease is due to GI hemorrhage, infection, perforation, vasculitis, heart and lung involvement, amyloidosis, and subluxation of the cervical spine. In the initial stage of the disease, joint effusion, juxta-articular osteopenia with erosion, narrowing of the joint space, and loss of articular cartilage are the features which are associated with rheumatoid arthritis. This hand affected by rheumatoid arthritis is showing the narrowing of the joint space, with the erosion that is more prominent near the margin, the proximal metacarpal bone especially near the proximal interphalangeal joint, there is osteopenia, and the carpal bone are showing ankylosis. For the diagnosis of the rheumatoid arthritis, this RA factor is non-specific, though it is present in about 80% of the cases, but it is not specific as there are more false positive and false negative cases reported. But this anti-citrullinated peptide antibody, it is diagnostic of the rheumatoid arthritis. Analysis of the synovial fluid is important, that shows increase in the volume, there is increased turbidity, and viscosity is decreased. The protein content is high, and the number of inflammatory cells is also increased. Sometimes it goes beyond 50,000 per microliter, but majority of these inflammatory cells are comprised of neutrophil. There is a diagnostic criteria for the diagnosis of rheumatoid arthritis. 4 out of 7 of these criteria should be present to diagnose or label a patient with rheumatoid arthritis, and these criteria are morning stiffness, arthritis in 3 or more joint areas, arthritis of hand joints, symmetric arthritis, rheumatoid nodule, serum rheumatoid factor, and typical radiographic appearance. These we have seen earlier. So this rheumatoid factor, which is antibody against antibody, is seen in many diseases. Some are rheumatoid diseases and some are non-rheumatic rheumatoid disease. So rheumatic are Sjogren's syndrome, rheumatic rheumatoid arthritis, systemic lupus erythematosus, mixed connective tissue disease, myositis, cryoglobulinemia, and it is also associated with normal aging. Various infections such as Hep B, C, subbacterial endocarditis, subacute bacterial endocarditis, TB, HIV, while it is also positive in non-rheumatic disease, sarcoidosis, and idiopathic pulmonary fibrosis. The aim of treatment for this rheumatoid arthritis is to decrease the pain and decrease the inflammation or to slow or arrest the destruction of the joint. The main drugs that are used for rheumatoid arthritis are non-steroidal anti-inflammatory drugs, corticosteroid and DMARDs, which are disease-modifying anti-rheumatoid drugs, which include methotrexate, lefenamide, cyclosporin, cyclophosphamide, azathioprine, sulfasalazine, gold salt, penicillin, and then there are antimalarial drugs such as hydroxychloroquine, tumor necrotic factor inhibitors, T cell co-stimulatory blockers, B cell depleting agents, and interleukin 1 receptor antagonists. Thank you for your attention. If you have any query, please write in the comment box.